Hi, everyone. Good morning, good afternoon, good evening. Uh, I'm talking to you from Albania in this amazing event. So, I want to talk to you about the multidisciplinary cases, which involve infants, of course, and how can we unify function and aesthetics in these cases. So, good news are patients are accepting implants more and more as a solution, but patients also want less surgery possible, and they want more aesthetic results than before, which is then why we need to take more attention to what we are doing. The implants, as we know, they need enough bone and soft tissues around them. Otherwise, they will fail soon or later on. They need a primary stability and good bone and implant contact. And of course, we need an acceptable emergency profile to mimic them as teeth. So, as Professor Linda said, the bone sets the tone and soft tissue is also the issue. Well, what we know that after we extract a tooth, we have a loss of dimensions, which is 3 to 6 millimeters in width and 2 to 3 millimeters in height after directly 3 to 6 months from extraction. So, how can we restore it? Because we need to get back what we lost. If we are not doing immediate implant, we need to get it back. So we need grafts. That's why we use them. And also we're gonna need soft tissue grafts. Otherwise, the implant we're gonna place is not gonna look like a tooth at all. What we see with the grafts we place? Well, we see them in functions short and long term, but most of them don't completely turn over. Lots of studies show that, but the good news is even though they don't turn over at 100%, they work. They do their work for lots of years, so we should not, let us say, take it completely as something that's not working if it's not turning over 100%. They should be a good scaffold and they should be bioactive. They should provide us with quick and stable results. Well, other considerations that you should be taken are indications for the grafting site, age, state of health of the patient, medication, smoking, and also something that depends on us, our skills and expertise, and also the patient's consideration, because a patient would perhaps doesn't accept some grafting or something else due to religion or something of his personal beliefs. Well, what we see in practice is that not always we succeed in what we are doing. So what's out there? Allo, xeno, synthetics, and autologous bone. Well, I'm going to stay to the two last options, which is bone and teeth. These are my favorites, even though I use other grafts to let us say, um, do enough for what I'm doing. But most of the time I use autologous and a tooth when I can. But autologous bone, as we know, it needs a secondary site to have it. And if we don't handle it correctly, it can resorb very quickly. And of course, there are the quantity considerations that have to be taken into consideration because we can't get, let us say, uh, amounts as we would like to have them. Where can we harvest intraorally this bone? Well, these are the sites that we use often. And how do we do this? Well, these are the instrument, and these are some old-fashioned ones. But normally when we place an implant, we don't need much bone. And a good medium to do that is this one. With this instrument, at low speed rotation, we can get huge amounts around the implant place and then at a distance. And another one of my favorites is a scraper. As you can see, had a collection of them, but normally the safe scraper twist is my favorite, of course, the curve version. Oh, so these are my favorite tools to get some bone, which is not much bone, but however, I'm doing also the other stuff that I showed you before. But these ones are for everyone, and these are usable from uh, the beginning of your surgery. Then there is the tooth. Well, the problem is it requires a tooth. But let us say often we've got teeth to extract that we didn't use, which is a shame. Uh, be aware that only in the US every year are extracted more than 20 million teeth, which most of them could provide a grafting solution. And I'm using Cometa Bio uh, machine to do that, the grinder, which in several minutes can transform them from teeth to grafting material. Well, another advanced option is to do it sticky tooth, which enhances their properties and makes it much more stable and much more usable. And this is in real time what I do. But I believe lots of you are using them now. So you crash the membranes over them. So, well, and is it a disputed fact that they are standard? So it's a shame not to use them. I'm not going to go around much, you know, theory, and I'm going to go to soft tissue grafting, which are these are the places where we mostly would like to get them. Palate is our preferred one, and then there's our other sites that have been used. Small quantity can be harvested all over the mouth. Another way to enhance them is to stretch what we've already got. And also, I like using the tunnel techniques and the soft brushing set is very nice to use, even in this case.
When you try your best but you don't succeed. When you get what you want but not what you need.
You stretch the fibers and then you can make place for the graft that you have. Also, another way that I always use is the BCGF fibrin clot that I collect from my blood with a direct venous suction. Most of you, I believe, are using it. It's now the trend of the time and it works very well. You will see in my cases that it's a very good solution to enhance the quality and quantity of soft tissues. This is what you get after you centrifuge it. And this is then the fibrin clot, which is the main dish that I'm going to use later on. Also, what's important is that we have an emergence, a natural emergence profile. That is why I come to these graphics from Alberto Miselli, who suggests that we should go deep into the bone, at least 1 millimeter, possibly 2 millimeters, and then we gotta have at least 3 millimeters of soft tissues above our implant to cover, protect it, and then to give the nice aspect that we need. I believe this is something that anyone would like to have. What I did before was that I had this plastic, let us say, plastic abutments that I could shape, and then I had to shape them the way I liked the soft tissues to come handy, and then you can take impression after you create these soft tissues. But then later on, I found the cervical system, which is very easy and predictable and can allow in a couple of minutes to have a very nice emergency profile. With this set in a little more than 5 minutes, you can make an emergency profile which is more natural than anything else I've used before. There is a vast choice to be used, and you can then use them directly to create the profile you need. So you can fabricate them easily. Even the assistant at the office can fabricate them easily. That's what I'm doing now. And you can even prefabricate them to use them later on. So I showed you some of my ingredients. Let me show to you how I bake. So I have lots of cases with teeth, since I've been using them for a lot of time. But since we are talking about combined situations, this is a socket augmentation with immediate implant placement in an orthodontic case. The patient is 21 years old, pharmacy student, with the edentally of number 25, which was in treatment orthodontically to have an expansion in order to allow me to place this graft. And then I placed the implant and flaplessly I grafted bilaterally with sticky bone and also BCGF membranes. So this is the prior situation. As you can see, there is a lack of bone here for the implant I'd like to place, because as we know, a couple of millimeters of bone surrounding the implant would be good if we want to have a nice result and a stable over time result. So in this case, laser cut, and then I started placing the implant and collecting the bone with the Unica that I showed before, and also my sticky bone down here, which was combined with beta-calcium triphosphate. In this case, I decided to expand. This is my expander kit. Other ways are usable, but this is what I've used in this case. And then I placed a 3.7 implant, I believe. And afterwards, a couple of membranes bilaterally and grafting bilaterally. So palate also, and then vestibularly. Then we created the emergency profile, as I showed you before, with this kind of plastic abutments that I have to create a these abutments are used in smaller laboratory analog to create the emergency profile needed. This is what we have after we treat the case. We take impression and place an implant and place a crown over the implant, which, as you can see, is ecstatically correct. Now let us check the bone in the CBCT. As you can see, from 4 it is passed to around 8 millimeters, which is then a couple of millimeters both sides, even more. Another case, a doctor this time, class 2 malocclusion, which had passed orthodontic treatment before, but with scarce result. And they extracted 36, created the possibility to 37 to incline anteriorly. Very thin gingival biotype and insufficient bone coverage of the roots. So at the first stage, I decided to do a corticotomy and a V-shaped piezo cut for my 37 to move. And then in a second stage, after the place was created, I decided to place an implant. So this is what we have. As you can see, there is very little bone to cover this area. And also, as you can see in the CBCT, 37 is very much inclined. So what I did with the help of my orthodontist, I created here a V-shaped defect, and then we place this device. Now we are using gels, but however, this one works very well. And also we grafted the frontal area and then placed membranes over it. This is what we have after 3 months. So we have enough place to place an implant, and the 37 is not more inclined. This is the situation in the CBCT. This is the implant placed, still the device is still active. And then the finished result, as you can see. Another case, class 1 malocclusion, retained 13, missing of 22, very thin biotype and increased SPE plan, which you will check later in the images. First stage was planned corticotomy with BCGF coverage in both jaws and extraction of 13 retained, and also orthodontic treatment. And then in the second stage, an implant was placed at number 23. So this situation is in the panoramic view, which is much nicer than in reality, because if you check here, then you will see it's actually more messy than it looks. So this is the intraoral view, as you can see. So we did corticotomy, bimaxillary corticotomy. It's a Baruti-Demirci approach. We covered them with BCGF membranes. And then orthodontics started from the Dr. Baruti. And then after, I believe, 5 or 6 months, I placed an implant. Still orthodontic happening. And this is the situation after. This is what we could achieve after orthodontics and after the implant placement. And this is then the final solution that we gave to the patient, which now can laugh. A case of a female, which is a little older in age, 55 years old, class 1 malocclusion and polydiastema. with broken anterior veneers. And we have also 36 and 46 missing, which was substituted with bridges. And as treatment plan, we decided to go with corticotomy to close the gaps, and then BCGF membrane coverage over it, and we placed TMI implants, both 36 and 46, and prosthetic finishing in a second stage. So this is the prior situation, which the patient wanted to change. This is the CBCT. As you can see, there is very little bone, so we don't have to just save the implants, we also have to save the teeth. And I'm strongly believing that grafting also is needed there to enhance their life, and so that implants are not needed before their time. So this is corticotomy. As you can see, the spots, this root is almost to be seen. This is serum to clean the places overall, and then grafting and BCGF. And then we place a couple of implants. Nothing fancy in the lower jaw. And this is then what we achieve after about 6 months. So this is the situation now. We treat the entire archive. We don't treat just our implants. That's important. So this is the aspect of my implants. Another patient, a vertical fracture of 15, resulting in bone resorption, and then also there is lots of bone missing vestibularly. I decided to clean and immediate place an implant. It's risky, but no patient would like to pass several surgeries. This is the initial situation. As you can see, this fracture wouldn't allow even a socket shield to be used. And this is the large defect that can be seen, and also bone is missing around the other teeth. So 14 and 16 are also in bad shape. There is also lack of bone in other places, but the patient wanted to, finish this one once. So I extracted, cleaned, and then I placed blue M gel to detox, which is one of my ingredients that I didn't show till now, but it is also one of the ingredients that I use most of the time to clean the sites where I want to place my implants. And the fractured pieces of teeth were, of course, used to do them graft, to do them sticky tooth, along with autologous bone and along with some bone grafting material. This is the quantity that we have. And also I placed cervical directly after my surgery. As you have seen, it is, let us say, with a small flap, but also I did a vista incision over there to graft in the front area. The other one was a cut only in the alveoli. Then I placed a palatal small soft tissue graft. All the time blue M gel was used. This is the soft tissue graft, which, as you can see, closes very well in less time. And this is the aspect that we have after 3 months. As you can see, there is bone to cover teeth and implant. So this implant here is surrounded by bone, which is more than enough to sustain it for a long period. So this is the immediate result, and this is still healing at 1 month, and this is situation at 6 months. As you can see, it improves with time. Another case, 58 years old patient, 48, fractured and infected 22, and the lateral cyst at number 11, which I decided to treat them both in one shot. Let's so say. I extracted 22 and I grafted immediately and placed implants. So this is the situation. As you can see, vestibularly there is no bone. This one can't be used for nothing else but to extract it. It is fractured. Half of the vestibular side is missing. So I extracted it, cleaned, and used it as grafted material. And also the lateral cyst was also cleaned at the same time at the number 11 here. So implant was placed, grafting material, and then this is a lamina from OsteoBio. I like it as a solution to cover when I want to be sure that everything will stay in place. Also, this is the other incision for the lateral cyst here, which was also treated at the same session. As you can see, grafting all over there too. And this is then the situation after 3 months. Soft tissue situation. And then this is how we finish it. Another case, female, 59 years old, with aesthetic overall problems. She wanted to change the aspect of this situation, which, as you can see, lacks bone and also is very traumatic as occlusion. And there, as you can see, these teeth are not doing very well too. So, laser incision in this case, elevation. I exposed and cleaned the infections in the other teeth nearby. Detox with blue M gel. And then I created the sites in the two, number 11 and 22, to do a 3-unit bridge with 2 implants. Slow expansion is what I use in this case. And as you can see, there is very little bone vestibularly. So implants placed in position. And as you can see, there is a small crack here. So, blue M gel, healing abutments. I didn't use immediate healing abutments, cervical or other, because I had a very large defect that I wanted to cover and I didn't want to force my luck in this case. However, they had a good primary stability, so soft brushing to expand the tissues, then cleaning with serum, and afterwards a first place here at the crack autologous bone, and then sticky bone over it, as you can see, all over the place, membranes of BCGF to cover it all over, and then a suture to fix subperiously. I use PGA in this case, and then a double continuous DPTFA suture to close the gap. And then over it, blue M gel was used. This is a situation in 2 weeks. And then the patient, which wouldn't like to stay without a prosthetic solution, placed her partial prosthesis over it, which was always kept with blue M gel. This is a situation in about 4 months. And I started to change the soft tissue appearance with my cervical VPI emergency profile creator. This is what we had in 10 days. After, we changed also the aspect of the teeth. As you can see, some laser corrections were done, and bridges over implant and teeth were fixed in the upper jaw. As you can see, this is the solution I gave to that aesthetic problem that the patient had. Another one, this is a recent one, 78 years old patient with an infection regio 31 and 32. The teeth were practically flowing in the alveoli. We have tooth lost vestibularly in the mandibular front. And I decided to go for extraction and immediate implant placement, and also immediate implant loading with cervical. You will see that the gap is very big, and in the frontal mandibula it's not easy, but the age of the patient and the problem is that he was not willing to have many surgeries, and I decided to take the risk with him together to do a one-time abutment treatment in this case, as you will see. So teeth were extracted, and during the time of the healing, he wanted to stay with teeth because he's a businessman and speaking all the time. So we did this kind of prosthetic solution, so he could use, not to stay without teeth. And as you can see here, you can see how accurate is the emergency profile created with cervical. The lab guy broke unintentionally this tooth, and then I could check how the 31 and 41 stay together. They are almost identical. This is the profile that you get with cervical. And I started surgery with greening these two teeth and then adding biomaterial and autologous bone, which will be collected with scrapers and also with my unicas. And this is the huge amount of bone that I have in this case. And this is the huge hole that I had in this case. The implants, as you can see, are placed very deep. And then this is the profile that you have over them. First, I place some autologous bone, and then the sticky tooth that I created, and lots of membranes, 5, 6, 7 of them, I don't remember now, but there are lots of them. This is the closing of the gap, and this is the situation after a couple of weeks. This is the CBCT at 3 months. As you can see, teeth also are important and are covered with bone, which wasn't there before. As you can see, it is even more than this. So we decided to undertake a kind of, let us say, experimental solution. This is a long lab screw, but in this, let us say, very small implants, this would fit well and create us a good abutment, which can be used to create a good prosthetic solution. This is the situation immediately after the provisory was placed. And we used the bite he had before after removing this two teeth, plastic teeth, there to cover and to protect our, let us say, early healing and a strong bite if the patient has one. So this is still in process, but I believe it's going to be a good case. The soft tissues are healing and it's going to be nice when it finishes. Another case, 36 years old, edentullia and aesthetic problems overall. So we decide to place implants and socket grafting and try to be as minimally invasive as possible. She wanted her appearance to change because she didn't like her aspect, and we decided to do it as soon as possible. These are the implant sites. This is the CBCT, As you can see, bone is not enough to support a good implants in place. So I go normally for 4.2 in molar sites and 3.7 in the frontal area. So if we have 5 millimeters at all, it can't support the 4.2. Doing the math, I need to graft extensively. And in these cases, I decided to go with piezo cut and doing split crests. This is the kit I used to center the implants before I got my cervical. It also works well. Cervical works better. Implants are placed in position after slow expansion of the bone. The bone is, of course, collected. And then this is the staged expansion. And then, as you can see, this is the situation after. Sticky bone in all the sides, also membranes, BCGF membranes all over it, and poncho technique from Professor Son, and primary closure. This is the situation at sutures removal in a couple of weeks. These are the sites, and as you can see, there are other changes to happen in our mouth. But what's important for us is that we have enhanced all the bone sites. As you can see, from before to after, it's passed extensively. And now we can module the soft tissues. I would have done it later, or let us say now, I would have done it in one stage. But before, I wouldn't like to risk it a lot, since the split crest is also something that would not allow us to make lots of bone pressure. These are other changes happening in our mouth. These are screws in to be used in other teeth. These are then the final situations changed after we decided to change the aspect, and this is the final solution. And the patient is happy. Another case, 54 years old. As you can see, the patient has lost the previous bridges, and we have a free end situation in the upper one. Also endos to be done, and new bridges to be placed, and implants also. As you can see, this is the situation before. This is a free end situation in the second quadrant. Endo also, since this is a multidisciplinary case, which are not always done by me, of course. These are the fiber posts that we use. The other side, implant side, as you can see, are very lacking of bone. So we decide to graft extensively. As you can see, there is this thin bone here to support our 3 implants, which has to be augmented. So we go for slow expansion, since in the maxilla it works much better than in mandible. And then we place sticky bone all over it, collected with scrapers and unicas, and we graft bilaterally. Insert healing abatements, soft brushing kit in action to create the place to put all that bone we are supposing to place. And then this is the continuous suture that I always use, double continuous one, and blue gel to cover it. Situation in 4 months, transfers to put a bridge, provisory one, and blue gel to help improve the situation. There are lots of other changes to be done in this mouth. This is still in process. Another case, 45 years old patient, dentulia in all 4 quadrants, but she chose bridges in the upper ones and a couple of implants in the lower one. So this is a deep bite situation and the bruxer. So we need to enhance the bite, otherwise it won't work and our implants and everything we do will go lost. Fiber post, as you can see, used, since this is a multidisciplinary case. Impressions for bridges in the upper jaw. And then we have this situation. And we also place a bite, a couple of millimeters bites to stretch the muscles to allow us to do our enhancing. This is a situation in the implant site. Osteotomy, slow expansion as I showed before, soft tissue brushing, and sticky bone all over it, disinfection. And these are these healing abutments that I like a lot when I don't place immediately cervical. This is what I use with poncho technique this time, suturing. This is the final situation. Emergency profile is now to be created. As you can see, there is extensive grafting bilaterally, both vestibularly and lingually. And then I started with my cervical profile emergence creation and impression taking. This is the 3-unit bridge, as you can see, supported by bone all over it and soft tissues also. And this is then the situation, which also has to improve in the frontal area with bridges to be placed or what the patient would like. But for now, we had to increase dimensions in the posterior sides. Well, now let us place a couple of cases with periimplantitis. This one is a good example to show that periimplantitis is a problem. And in this case, a patient of 56 years old is missing lots of bone around her implants placed about 10 years ago. And she is also having hypothyroidism and controlled diabetes type 2, which doesn't make our work easy. So we decide to explant and to place TMI new implants inside in this case. This is the pre-op panoramic. And this is a situation we had in mouth. Bone condition, as you can see, is painful in each side. But I decided, however, to remove them and place directly my implants. This is an implant extractor kit. You can find several ones. This one worked in this case because there is almost no bone to keep these implants. And this is the ingredients to place new implants. I'm going to go a little faster because we have a lack of time. And this is the situation after I placed the implant and also grafted extensively. And important thing is to know that the 3D examination is always needed because, as you can see in this one, you see me placing an implant in the nerve, which is absolutely not true. Because if you take the CBCT, you will see that there is no contact whatsoever with the nerve. The implant is laterally and it's not perforating anything. Patient has no loss of sensibility or something else, so nothing is there. Giga formers were placed at 3 months. Since, as you have seen, I covered it all, I wouldn't want to risk since it was a very massive augmentation. Resin bridges were placed for modeling because the patient wouldn't like to go many stages. And in about 4 months, I placed the resin bridges, and then in a couple of months, this is the final zirconia ones. And Bloom gel is used regularly since she needs all the help she can get with her hypothyroidism and her diabetes. And this is the final result and the 1 year follow-up. Nothing has changed. This is about 3 years now, but it's all good. Another patient with a dentulia with aesthetic overall problems. As you can see, the lower bridges are uh, very long, but they were in function for 10 years, so who am I to complain? But now these teeth can't do their work anymore. And also the situation in her mouth is dramatic, as you can see. I extracted the two molars and used them as grafting material. Endo teeth can be treated too. My first case of endo treated tooth has 4 or 5 years now and is doing very well. But of course, you have to clean all what's there. So the sides, split crest in both sides. Implants were placed 2 and 3, one side 2 and one side 3, or 3 or 4. I believe it is 3 and 4 now that I think it better. So implant placement, soft tissue expansion, and then here you can see that I placed a laminas of osteobiol over this ones to support my sticky tooth. And then I fixed them with T-cell, courtesy knowledge of my friend Enzo Foti, which I'd like to salute. And this is the situation. I compared sites suturing with two different sutures, which didn't change much in the solution. As you can see, this is the situation in 4 months or 3. There is lots of grafting there. And we can start change her aesthetics in the upper and in the lower jaw. We are not always free to change everything. The patient is at 60s, so she doesn't, let us say, want a perfect aesthetic solution. So we have to do compromises also. Endo is done. These are the fiber posts that we use. And this is the situation in the upper and the situation in the lower jaw. And this is the aesthetic overall. The patient is happy with what she's got. Another case with extreme odontophobia, which was treated in general anesthesia, patient of 34 years old. This is the situation before the treatment, which is painful. Well, this is what you get when you don't like your dentist very much. And this is a CBCT, which shows almost no bone in the front. The canines are floating. One was removed by itself, as you have seen. This is the CBCT reconstruction, and this is what we started doing. We removed all the teeth and used them as sticky tooth. The situation here, and we placed 6 implants. I would have liked to place 8, but at the canine site, it was dramatic, as you have seen. Reconstruction, and a couple of laminas to fix the healing abutments. So this is the situation after suturing. I left on purpose the wisdom teeth to keep my occlusion. I wouldn't want to change it. And this is the situation at 3 months. These are my 6 implants inside, which are doing very well, as you can see. And since the patient is young, I was going for all on 8. In this case, however, the soft tissue was to be modeled and the patient doesn't have to stay without his teeth. So this is the provisory. And impression, which meant he now is taking much more care to his teeth, and we started to change his appearance also in the lower jaw with an orthodontic treatment. But what was important for me was to see that this bone at 3 months is with an aspect of a normal bone. As you can see, this sticky tooth is doing very well. And I was able to place my implants. This is the situation after. And these are the 8 implants in mouth for a fixed all on 8. As you can see, 8 implants inside, soft tissue contouring. And this is the final solution at the try-in. And then this is the upper and the lower jaw treated and with the soft tissues to improve. But the patient now can laugh, which is something that he haven't done for years. And some artistic pictures from Dr. Baruti. Another case, maxillary adontulia due to parodontosis, extraction and all on 8. As you can see, the situation is painful before, everything is moving, and in the CBCT also, so it needs extensive grafting. All sides are in lack of bone, so as you can see, I extracted all these teeth and I went for a surgical guide to, let us say, guide me, but not so helpful in this case. The teeth were extracted and sticky tooth was produced. Soft tissue was enhanced and improved also. Sticky autologous bone and sticky tooth all over the 8 implants I placed. And then I decided to take an impression immediately, and I loaded 6 of them, and the frontal one, which had much more grafting, as you can see, I decided to leave them for a later one. In 3 months, I also placed them in a new plastic bridge. This is the situation after 1.5 months. This is the situation at 3 months. But at this moment, the patient comes with problems in the lower jaw. What's the problem? This one was a predicted problem, a cyst in the lower jaw, possibly coming from this tooth rest or endotrit here, which made now problems. I wanted to treat that in the first moment, but the patient didn't agree. And then we had this hole here, which I also grafted. And this is the situation after it. And here at 3 months, the lower jaw. As you can see, the grafting is huge. And this is the situation in 3 months at the upper jaw. I starting correcting, and then the upper jaw is here, and the lower one has got a scalectric solution for the moment because the patient would like to place implants there, but in a later time. And this is the situation before and after. Major improvements, as you can see. Another case, all on 8. I'm going to go very rapidly. Lots of problems in this patient. As you can see in the CBCT, I went for planning with edges, easy guiding implant surgery, extraction flaps, grafting all over, 8 implants placed, all on 8. And this is at the placement, and this is at the 3 years recall. This is the patient afterwards. Another one, all on 8. All implants were removed. As you can see, I'm going rapidly because I don't have much time. I would like to show you a couple of treatments, later treatments of periimplantitis. So, situation at 3 months, all on 8 in place in 1 year later. Another case, parodontosis, and here I went for a combined solution, all on 4 and all on 6. All on 4 in the lower jaw, all 4 teeth were extracted, but as you can see, there is this very thin bone, which I didn't want to go much lower because that would create a very big gap with the upper one, and I don't want that for my patient. So I removed the teeth, which has to be used later in the upper jaw, and then I reduced the bone, but not much, with piezo, and this bone was also used. And don't even think about me throwing some teeth. It won't happen more for lots of times. So this is the all-on-4 in the lower jaw, and this is the sticky autologous bone with the bone that I collected as I showed before. Sticky bone in place, membranes closing, and immediate CBCT. As you can see, improvements all over. This is the solution that I used in this case, removable because the patient is not in Albania and I can't check them very well, and I wanted her hygiene to be good. But as you can see, it's not so removable as you would think. The patient has it difficult to remove. And then we have to think about the upper one because this is the situation in the upper jaw with a cyst here. So I went for stage approach. The teeth were grinded, sticky bone, and these are the clouds that I place over them. And this is the prosthetic solution, the old one. And this is the situation in 3 months. As you can see, this is the situation now. And now I have enough bone to place 6 implants, as you will see. So, palatal approach, all on 6 in the upper one, immediate impression, and sticky bone a little more. And this is the solution in the upper jaw, similar to the lower one, but with 6 in the upper one. This is the situation in the CBCT, and this is the final situation of the patient. Another patient with this disastrous approach, but he was also afraid of the dentist, and this time it's all on 16. So I just want to show it rapidly because there is no limit to what you can do with what you need to do. And this is a situation of a patient that was treated all the time in general anesthesia. A couple of cases of periimplantitis. A patient of mine, 30 years old, known her since 2004, with this situation here. After orthodontics, we created place here to place an implant. In 2004, this was the solution that was given to close that place because of the young age of the patient. A TMI implant was placed. At the time, not as good, but not as bad solution. We are talking about 2007. Now our knowledge and experience is much different. And in 2018, I decided to improve our situation. I did a tunnel technique with soft and hard tissue grafting. At the same time, as you can see, palate graft was used. And in 2020, I changed also the situation in this teeth. So at one shot, I decided to improve teeth and also implant. This is the situation now. As you can see, is much more improved than it was in 2004. And this is the view that Dr. Rado wanted so much to see. Another case of periimplantitis, a patient where I placed an implant 10 years ago. This was the situation. I placed an implant which was not bad at the time, but uh, after 10 years and after not seeing him for 4 years, he said that the implant was moving, but it wasn't the implant that was moving. The prosthetics was moving for 4 years, and this is what it created. So what I decided to do is to do something else. I tried to think what I could do, and I wanted to save this implant. So what I did was I extracted the tooth and I did a tooth ring, partially decalcified, about 60%. And then the rest of it I used as grafting material with some more grafting material as well. So this is my first case of periimplantitis treated with tooth ring and is still in progress, but I just wanted to show you for this event. I hope you liked what I showed you, and as Dr. Gordon Christensen says, socket preservation should be a standard of care, so please use it, your teeth, and do it all the time because it will save you much more problems later. This is an old picture, an Albanian photography picture, and you can find me in this sites and also my email. Thank you very much, and I hope you enjoyed my presentation. And I'm waiting.